Welcome to a ward, which is like a lab, where our student researchers reside 24/7, and each patient that you see here is a separate project. Today, in this quick demonstration on patient as a teacher, we shall take you on a journey through our lab, and after one of our student researchers shares his recent patient-centered innovation idea learned from one of his patient teachers, we shall shift focus to another particular patient from whom we have been learning for quite some time now, since his admission. The objective here is not only to demonstrate how we may learn from patient teachers, but also how we may help them with newer low-cost tools as well as financially through crowdfunding.
He's having temperature spikes, fever spikes. Right now it's 99.3.
Arterial arteries.
Yeah.
Every night I am observing this patient for collecting quantitative and qualitative data and doing literature review to build low cost monitoring and treatment in case of sleep apnea.
We shall simplify a patient-centered learning methodology with this acronym SOAP, where what you are currently observing in his body are some of the objective findings of the SOAP that we can glean visually, and soon we will demonstrate more objective findings to you using technology. So we would like you to learn from this patient why he has these pulsations on his neck and precordium, and now when you observe his back, you may notice that the right side of his chest is moving less. And when you watch us percuss on his chest, you can hear that it's dull. And if you're able to hear the sounds caught through the stethoscope using a microphone, you will realize that they are very much reduced in intensity on the right side of his chest. Our patient teachers expose us to an ocean of subjectivity that we student researchers try to make sense of by converting into objective event data points that you see in the slides here. This particular patient whose findings in the chest and jugular pulsation you saw earlier has not only undergone tremendous suffering himself, but he also has a history of tremendous suffering in his family, with many members dying of hypertensive stroke and renal failure. He's on dialysis and his father is also on dialysis, and one of his elder sisters passed away with renal failure 2 years back at the age of 35 years. His creatinine admission was very high and his first dialysis was punctuated with bleeding from the catheter site. Now let's move to the A of the SOAP by analyzing and assessing these subjective and objective data along with our students. Let's say, where exactly is the problem?
He has a family history of CKD, but maybe initially he had hypertension. His father had hypertension when he was around 40 to 45
His
years.
father had hypertension at the age of 29 only.
Yeah,
29.
same age.
29.
But can you formulate some more questions? Like, let us say, okay, where is the problem? We have found out that it is, this JVP is giving us a clue that it is because of a heart problem. Yeah, the pulmonary artery system is, the pressures are increased, so that's why the JVP is reflecting that. And you can see that the heart is also quite enlarged and very prominent. And if you put your hands, you can feel the apex. And we've done an echo, we've seen that there is a left ventricular hypertrophy. So all those things are indicating that there is a cardiac issue. And that cardiac issue is a fluid overload because he's got a renal problem. And not only that, this renal problem is causing hypertension, which has caused his heart failure. So renal problem, hypertension, causing heart failure, causing pleural effusion perhaps to an extent. But on top of that, over the last few months, he's also developed a secondary problem which could be an infection. So pleural effusion is partly because of the heart failure, partly is also because of the infection, which is causing inflammatory changes from time to time, and that is what we are seeing. So this is the where of the problem and why of the problem. But then what can be done about it? So what have we been doing?
Treatment for pulmonary artery.
Yes, exactly. That's a very good question. So if he has got pulmonary arterial hypertension because of heart failure, what would be the treatment? So as we know that we logically use preload reducing agent or afterload reducing agents. So we are already using that on him. We have given him all kinds of antihypertensives. So many types of antihypertensives. Now,
Endothelin antagonist.
Endothelin antihypertensive.
yeah.
Endothelin
So what is the
antagonist
role of
reduce systemic hypertension.
endothelin antagonists or even
can use
pulmonary
iloprost.
vasodilators like
Prostacyclin
Prostacyclin
analogs.
prostacyclin analogs or even phosphodiesterase inhibitors.
PD5
Yeah, what are the roles of
Hydroxide.
these kind of medicines in such a situation, which is basically a secondary pulmonary hypertension because of a cardiac cause. mostly. And this cardiac cause is also what we are labeling as heart failure with preserved ejection fraction, because apparently his heart ejection fraction is preserved, but we know that his heart is not able to bear the load. So, what is the role of these therapeutic options in that? So, that is one important question.
Hypertension
And
will be causing endothelial injury.
yes.
Endothelial injury causes release of endothelin.
Yeah.
Endothelin in turn causes vasoconstriction, systemic and pulmonary, and
Very good.
causes
So this is the
hypertension.
traditional logic-based approach based on animal models, where we formulate a hypothesis saying that yes, this is the pathophysiology. So if we hit this pathophysiology in these stations, we will achieve cure. Now this is good, but then does it really happen? So for that we have to do trials, human trials. So this question will be answered in a PICO format if we can see how many patients have been already studied like him who have got secondary pulmonary hypertension, not primary. And you can study the effect of phosphodiesterase inhibitor, you can study the effect of endothelin antagonist, or you can study the effect of prostaglandin analogs. So there will be separate studies for that. So you have to tell us how many patients were involved in these studies, how many patients were there in the intervention group who received prostacyclin or sildenafil or this, and how many were there in the comparator placebo group, and what were the outcomes. That is what we have to see. Now similarly, he has got another problem. He's got anemia, severe anemia. His current hemoglobin after so many blood transfusions is around 6. So what do we do for anemia and renal failure? So is erythropoietin going to be beneficial? So do we have placebo-controlled studies of erythropoietin, where erythropoietin has been given and placebo has been given, and have they compared it? So that is another thing which we have to look for. So Zain, what other questions do you have for his around what can be done?
Sir, the uncertainty regarding his pleural effusion.
Okay, so one is the uncertainty, the diagnostic uncertainty. Why does he have pleural effusion? Yes, we did try to tackle that by doing a pleural tap, which you saw was quite hemorrhagic. And what did we find on that pleural tap? We found exudative with lymphocytic pleocytosis, which could also suggest a tuberculosis inflammation, or it could be even inflammation due to other causes. So there is a diagnostic uncertainty, we were not sure. So what did we do to tackle the diagnostic uncertainty? We gave a therapeutic trial. So we put him on antitubercular therapy,
drugs.
and we have been seeing how his fever is responding.
His weight gain is improving.
So he is improving weight, his appetite is, we cannot be sure. His appetite is improving and his fever has come down. So we cannot be sure that it is all because of antitubercular therapy, but yes, I mean that's all we have got.
Therapy might be acting on another infection that might be there.
Yeah. Achha, so what other infection can persistently cause pleural effusion other than tuberculosis? Yeah, we have to think of that. We'll have to look it up. Yeah, that's a good question. Yes.
Which is selective ETA and ETB antagonists. They showed improvement in 6-minute walking distance without breathlessness. And BNP levels were also measured, sir. BNP levels were also reduced. I mean, heart failure was also
Yeah, no, I mean you're looking at the markers, but what really
markers
happens?
and 6-minute walking distance. Symptomatically also the patients got better with ampreset.
And were these all patients of secondary pulmonary hypertension?
Mostly, sir, secondary pulmonary hypertension. Only 11 patients were not diagnosed, sir. The cause was not
Okay,
diagnosed.
so that would be primary.
That could also be
Could be secondary,
or
but yeah, of course, primary.
undiagnosed secondary.
Yeah, primary is always like maybe undiagnosed secondary.
Yes.
So, but then what secondary hypertension did they have? Were they all having
Connective
this kind
tissue
of
disorders and HIV, sir.
Okay. So what were the reason for?
It was not
that?
cardiac cause.
Yeah, exactly. And what would be the reason for retrovirus causing this pulmonary hypertension?
Not every case you can reach to a diagnosis, but one case is being projected which has a complex presentation.
So, to summarize drastically, if we are to quickly address the weaknesses and threats of learning from patient teachers, many students who are used to passive memorization of facts and fitting it to real patients, the diagnostic and therapeutic uncertainty generated in patient-centered learning can be an immense challenge to master. Coming back to our patient, in view of his strong family history, we think the reason why he has the hypertension and renal failure and stroke in his family could be fibromuscular dysplasia, which though underreported is not impossible. We have sent his buccal cells for a genome study. The threat to protecting patient confidentiality can become challenging while learning with collective groups over time through blended medias, and yet the rewards often outweigh the risks. And as long as the goal of our learning is to help the patient at hand, one can still manage to tackle the challenges that are hurled every day. Our student researchers have already created a crowdfunding account to help finance this patient's further management that also involves renal transplant. We welcome all of you to learn with us in our case based blended learning ecosystem, the offline component of which is hosted here in Narketpalli. And we look forward to sharing your collaboration with us through case study publications in BMJ, who also happen to nominally support this program. Further contact details and past publications of a lab, along with student and faculty online learning portfolio links, are available at the web page where this video you watched is being hosted. Thanks for watching.